Hello.
Yeah, no. You guys hear me? Hey, Jaime, can you hear me, Jaime?
Yes, I can.
Perfect.
Thank you. Gracias, Jaime.
Everything's good.
Good. Ready to
Everything's good. You and I are the first ones on. This is unusual.
go. But
Hey,
I'm the first one, thanks to Jaime Jr.
Jaime
Bye-bye.
Jr.'s back
Big
there.
hug. Take care.
How you doing? You coming to Porto?
Un poquito más alto, que no oigo. Más o menos el volumen un poco, por favor.
Es que no sé, es que estaba tan alto.
Sí, pero si ahora no oigo, todo este esfuerzo para nada.
Good. Ah,
¿Cómo se sube?
there we go. Cacao. Welcome.
Hello, background. Nice to meet you.
Nice meeting you. Thank you for joining in.
Yeah.
Are you all ready?
Yes.
Good.
Good. Yeah.
You haven't sent your money to our bank account yet.
Send money?
Well, if you want to get a good score from me, yes.
Yeah. Yeah. I'm not yet. Sorry.
It's okay. It's okay.
Oh, okay.
Professor Robert.
Good morning, everyone.
Good morning, Korai. How you doing?
I'm good, thank you. How are you?
Battling a migraine today.
Oh no. You've frozen. How's your connection?
Everything good down in London? My connection, I think, is fine.
Okay. No, you just froze for a second as you were talking.
Oh, oh. That's because I'm a cold fish. I freeze all the time. How's
So,
everything down in London?
yeah, it's rainy as usual.
Well,
No, no different.
it was beautiful blue morning in Manchester when I woke up, and it's now gray and cloudy. And I think we'll probably get our asses kicked at this match today against Liverpool and get soaking wet at the same time. So it will be a bad day. Have you seen, Corey, the criteria we're using, or the four different things we judge?
I haven't. I haven't.
Okay, yeah.
I've only
You have
been
a pen and
sent the
paper?
link and the challenge pathway, but
Yeah.
not the criteria.
Okay, that's on the website. I have a website, but it's fairly simple. It's we judge one, we give 1 to 5. Five's the highest,
Yes,
and we judge the complexity of the case,
yes,
the quality of the documentation,
yes.
the treatment rationale, and the presentation style.
Okay.
The one issue we've had is with complexity of cases, is we've had some
I can't. You're breaking up again.
you can't give a single tooth case a 0 compared to the 5 if it's a interesting complex single tooth, if that makes any sense.
I
Okay,
understand.
so next year we'll probably we'll rethink this, and we'll Robert and Roberto from Italy are working on changing it so that we'll have more simpler cases in one group versus more complex cases in another group. So we're learning as we go along here.
I will keep that in mind.
Yeah. And Christian's back with a big smile on his face.
Hey,
Welcome,
good
Christian.
morning. Good morning, everyone. Or good
Good
evening
morning.
morning.
Good morning.
in Japan. Hi.
Good to see you.
Good
You might
to
not have met Corey.
Good morning,
Corey's
Christian.
the one. Corey's the one who looks like an Aboriginal white man. You got to turn your screen down a little
I
bit.
think I always have this problem. It's a good camera, but I've got the light right in front of me, and I think it tricks it, so I can't. There doesn't
Oh, it
seem to be any
tricks
other
it a
settings
lot.
on it. Am I that pasty?
Okay.
Or I just sort of sit back a bit?
Yes, you're totally white.
Okay, just 1 second.
We can almost
Let's
not
see.
even see that you're wearing glasses.
Better?
And Christian looks like he's been on Mars. He's all orange in the face. No, you're still white. You're still white.
I'm still white. Okay. I don't know why.
Christian's
I
been
think
out
maybe
in
it's
the
just
sun
the
somewhere. Christian's been
screen
up in the
whiteness.
mountains in the sun.
Oh, okay, okay.
Why don't you turn the brightness down a little?
Me.
Yeah. Yeah. You turn the
There's
brightness
no
on the
camera
screen.
control. There's even on it's on minimum. So if I put
Yep.
video settings, adjust for low light menu, it's that's all I get,
Okay.
unfortunately.
Well, as you notice, this time I'm not wearing my red United shirt, but I do have a Manchester United t-shirt on. So we're waiting for Liverpool to kill us in about 3 hours.
Oh my God.
Okay.
There's Catlin. He's there. Very good. Is that Deborah coming on then, Jaime from Spain? Do we know?
I think so.
Is that her number? Good.
David, should we shortly try to present something?
I think that would be a good idea, that each of you try to put on your full screen one at a time. Robert, do you want to control that? I can't hear you, Robert. You're muted.
Sorry, yes, hello. I
Yeah.
can do. So, but where's Roberto?
He'll be on, I'm sure. He's Italian. Give him time.
Yes.
why don't we try to get our four wonderful presenters, get them to share their screen to make sure it works fine? Yeah, we need this to go on time, gentlemen, because as I said, I have to get to the stadium for a football match. So,
So, David, I try it. Could everyone
Yeah.
see? Could everyone see my screen?
Not yet. We're still seeing you.
yeah, no,
I
the
can
screen
see it.
there.
See it?
I can see
I
it.
may have it on the. Oh yeah, got it. I've got it.
That's
Wait.
perfect.
Everything ceases?
Yep.
Okay, perfect.
That was good. That was number one. Who's next?
I will share my screen next, okay?
Thank you. Beautiful.
Let's see my slide. Thank you. It's Tokyo Tower. Okay. No problems? Correct movement?
Hello, everyone. How are you?
Thank you.
Roberto.
Hi. How are you guys?
Good.
Good morning.
Very good.
Are you all ready, guys?
Ready to go.
Hi, Jaime. How are you?
Good. Buongiorno.
We should provide Koray with and Jaime with the background. Koray, shall I send you a background by mail?
I'm on the website and I've had a look at the rules.
Okay.
So I've read those. But anything you want to send me, of course, I'd be.
No, just the background so that you have the virtual background like everybody else. Let me
Oh, I
send.
see. Okay, right.
Just a second.
Jaime, do you have Jaime Jr. or Alfonso that to help you put the background on?
Así me puedes poner el background este. Me pide David. Alfonso is coming over.
Hello, everyone.
Alfonso.
Hello.
Hey, Alfonso, how you doing?
I just came back from running.
I can see that. Alfonso, I need 10 minutes of your time in Porto with a very, very good Danish dentist. I want you to look at a case that I'd like you to consider publishing.
Sure, but we're gonna have to do it through Zoom, Dave, because I'm not gonna be in Porto. My baby's coming at that time.
Your baby's coming a month before. What's the problem?
My baby's coming at the beginning of May, and I need to respond to my daddy functions, you know.
Okay, well then let me send
But
you
we
an
can
email
Zoom.
with
We can Zoom,
with-
Dave, and we
with
can look at it
Jacob.
together.
Yeah, okay, I'll set something up with Jacob, but we can do that, next couple of weeks, well before the baby comes then.
Sure. Also,
Good. Thank you.
of course.
Okay, we sent you the background, Koray. So
I got it. I got it.
Roberto, can you tell Alfonso how to put the background?
Yeah, no, I know how to put the background. I just need where's the background saved?
I send it to you by mail right away again. So to your dad's mail. Just a second.
See.
Coming up.
Vamos a conectar a tu mail.
Tienes ahí mi correo.
Ah, el de abajo.
Okay, it's coming by mail. Just a second, you should have it.
Yeah,
Thank you.
I'm even
That's
whiter
good,
than the
Koray. That's
background.
great. Well,
I
we have,
Gonna
Perfect.
slide this over so I'm looking at the camera.
We're looking very good today.
That's better.
or
Okay. Yeah, got it.
blue man
Okay, so
with used in black instead of blue. No head.
Did we try all the participants' computer? Everybody is okay with the screen sharing?
Yeah.
Okay.
I can try to share my screen.
Yes, try
Okay.
pause. We see that everything is okay. Perfect.
That's excellent, Paul.
Very
Oh.
good.
Great. Thank you.
Okay. Did you get the background, Jaime?
Yes, I did. Let me see if
Okay.
it works
You
now.
just go to the video, the arrow up, click, add the virtual background, and then select it. That's it.
Okay.
Can I
You go
try to share my
to
screen?
click, choose virtual background, click, and then there is a little plus in the bottom. You add the virtual. I mean, sorry, on the right, upper right side between the screen and the virtual background, you can press plus, add image or video, and then you add the. That's it. Perfect.
Yeah. Thank you, by the way. We talk, Dave. We can
Yeah.
WhatsApp.
That's okay.
Yeah, bye-bye.
Can I try to share my screen?
Yes, sure.
Yeah.
Please.
Oh, is
Perfect.
it good? Perfect.
Very good.
Okay.
Yes.
Okay.
Perfect. Okay.
Thank
So
you.
everybody tried. So we are all
Yeah.
set. Perfect. I was very lucky because yesterday
Okay.
I went to give a lecture
We
very
need
far away
Deborah.
from home, and I forgot the computer charger in the lecture hall. So I was able to charge my computer with the iPhone charger overnight.
Well, I hope this I hope my computer will last because I'm sitting in a corner of a hotel room and there's no plug here. And I don't want to take this over to the bed where there is a plug. You don't need to see me lying in bed.
Okay.
So
No, thank you.
Okay, so I think you are all experienced now. So aside from Koray, that is the first timer, everyone else has already knowledge of the rules and of the game. This time, since we have the first semifinal, we will elect the team that decides to go first or second by drawing. I mean, I still have the queen's coin, so I mean, this is nice queens or the head or tail, and the Germans will be the one that can choose head or tail because they won by the larger margin, because they won by 10 points in the previous round, and the Japanese won by 7 points. So I don't have to explain it live, but I will just give the option to pick head or tail to the German. I mean, to the German, and then the winner will decide who's going first or who's going second. Any
Fine.
question?
Perfect.
Okay. So Koray, have you reviewed the rules, even if I will enforce it before we start?
Yes, I've read through them once, but I can read through them again. It's
Perfect. So anyway, the participants will give a 15-minute presentation, and we will not discuss at the end of the 2 presentations, but at the end of the 4 presentations, so that you really have the whole. You make your notes while they're presenting, and then at the end of the 4 presentations, you will have 5 minutes each to interview the 4 participants, and then to send the vote through the chat in Zoom, so that I can collect the points, and then we can reveal who's going final.
two things, Roberto.
Yes.
You send the link to Deborah. Deborah's just asked for the link again on IFED Exco WhatsApp group, but I thought her telephone number down there, the +34, was her. But can you share the link with her, please?
The link to attend, it's everywhere. I mean, I just posted it on Facebook.
I know.
2 hours ago.
we have some people that have problems finding
I
emails.
send,
and-
I send it directly to Deborah, no problem.
Please, thank you.
No
And
problem.
may I come with a suggestion about the questions and answers? Robert, let me know what you think about this. If we could, each judge can keep the questions just to one per person, because sometimes the judge who is the first one to ask the questions asks 3, 4, 5 questions, and then
And
I
they're the
might not have
same.
anything to after that. So can we ask each judge to find one question that they think is the most important for each presenter? Is that a good idea?
Yeah.
So why not?
Sounds
Yes,
good.
sure. As
Good.
long as the judgment is fair, there is no problem with that.
Well,
Whatever
you know,
Roberts agree.
yeah.
Yes,
Well,
yes.
Roberto, you know it's always fair. It depends on which
No,
presenter sends.
absolutely. I think we have to
No,
make
no,
it, we have to make it interesting and fun at the same time. So
Well,
the
it,
people
well, it always
people
is
watching
interesting. It
enjoy.
depends on which presenter sends the most money to the judges. That's all. So
We know that. They have
it's
all
like
the
a football
participants
referee.
have the IBAN of all judges, so I think they
Yeah,
should be
please.
all set.
At least Paul thinks it's funny.
Paul is very brave because I've seen him going into very cold water early in the morning. How is that experience, Paul? I could never do that. I have a hard time to go in the water in the summer if the water in the sea is not very warm. So I couldn't be able to do anything like that.
But you should try it, Roberto. It's
No,
amazing.
I know I should, but I'm afraid I will die.
Oh, no, no. I hope not. But afterwards, you feel really great.
No, I'm
That's
sure
amazing.
that kick gives a big kick in the morning
If you
to
do it
kick you.
once, you want it later on, always. Yeah, it's
Oh, yeah.
amazing.
Some people do it in the snow, so it's mostly the same thing, but they go in the snow naked.
Roberto, many people are just stupid. So it's just.
No, I know, but I live by the sea and I like the warm weather, and I when it's cold, I really need layers. So when I see people going in the water in the snow or something like that, I feel very, very cold. But I'm sure that is good for the body. It's a nice temperature shock.
Reminds me of Saltstrand, where they got me to dive into a Norwegian fjord, and I dived in and I dived straight back out again.
Of course.
I'm Turkish.
Yeah.
I'm like you.
The good
Warm
old
it
days.
in.
When I went
Nobody-
canyoning once, and when you do canyoning, you go into the rivers, and the river water is coming from the glacier, so it's very, very cold, and you have the wetsuit, so it's a little bit better, but your head, my God, I felt like the brain was freezing, and then the next moment I was out of the water was a it's an experience.
Well, that's the advantage being like me, Roberto. There's no brain inside that skull, so nothing freezes. Very simple. Nobody's wearing green today. I'm very disappointed.
Yeah,
Today
but
is
because the
St.
blue
Patrick's
makes
Day.
a better contrast with the background white.
I know, but it's St. Patrick's Day, people.
I can wear if you want to.
Oh, Christian got it. Very good.
I thought about it.
Well, have you been to Chicago on St. Patrick's Day? They put green dye in the
It's
river.
true.
Yeah.
I thought you would wear red because is Manchester United not played today?
I'll tell you, if I can show you the picture out on the streets of Manchester, it is red today. Everybody is wearing red shirts outside today.
What's
So,
the game today?
Yeah,
who's
I'll be
Manchester
at the
playing?
match. That's why I want this to finish. Manchester, Liverpool.
Oh, that's a big game. Red versus
Yeah,
red.
who is right?
Yeah.
Yeah. Well,
And Liverpool
Manchester
is
will be
first,
red.
right? Liverpool is first and City is
No.
second.
No, Arsenal is first, then Liverpool, on the same points, just goal difference, and then City. City won yesterday in the this is FA Cup quarterfinals.
Okay.
So that's one of the reasons I'm up here. So Kathy's home with the dog, and I'm a masochist, so I'm looking to get my ass kicked this afternoon. Of course, it's me. You know, it's not the team, it's me. So it's
Wonderful.
it will be a fun day. So
Is
looking
Katalin
forward to it.
online also? Are we actually
Kathleen was on before.
Hi
Yes,
Katalin, how are
yes.
you?
Hello, hello. I'm fine. Hello,
Are
everybody.
you everything okay?
Yeah, yeah. Everything okay.
Good, very good. So
There he is.
well, Robert, maybe when we will be live, you will also have to say that we have a prize in Istanbul, and what is the prize in the final, so that the finalists will be more motivated.
Yeah, but we did not yet exactly define the price, but I will say something, of course, and let me just. So, just to show also here the Istanbul
Yeah.
meeting. Okay. Good. This.
I have all of our presenters today. Have you all booked Istanbul, or are you waiting to see if you have to be there for the final? Christian's nodding his head. He booked.
No, I wait.
You wait.
Be careful, because I forgot and I booked the past week, and the prices are crazy. I mean, I used to fly from Genova to Istanbul with 200 euro, and my ticket was 1,000 euro this time. So it's in Italy it's a holiday. So I mean, probably that's because of the Italian holiday. April 25th is Liberation Day in Italy, so it's a holiday. But the prices are crazy. It's just simply twice as much or 3 times more than before.
Yeah. Well, Corey and I booked months ago. So
So the day we're going is Republic Day, the 23rd of April. It's the day that Ataturk allocated to the children, so it's known as Children's Day.
oh,
So
Okay.
there'll be a bit of festivity there on the 23rd when we fly.
well, that would be very appropriate since the two of us are very childish. So they'll celebrate us.
Just from the way we look, people think we're adults, don't they? As a result of our age. I don't know why.
Well, the gray beard, you have 4 weeks, Corey, to get the gray beard.
Well, I'm working on it. It's gray.
Yeah, I'm the only one. Paul has a little bit of a beard. Roberto has a nice gray beard also. Yeah. Paul's not old enough to be gray.
Not yet.
A little bit.
Yeah, mine turned very gray. What's that? Okay. 2447.
Give us a speech, Robert.
Sorry,
Give us a speech.
I am the speech. What?
Give us a speech.
No, sorry, I'm just working. I have to send Deborah the link.
Okay.
Good.
I'll be the one also. Let me see.
I don't know.
You know, guys, before we have any ladies joining in,
Oh, here we go.
they say a speech should resemble ladies' dresses.
Yeah.
Long enough to cover the essentials and short enough to keep it interesting.
Very nice.
you remember where you heard that the first time, Jaime?
Yes, of course. But now I can't tell this anymore. I can be kicked out of the room if I tell this in Spain.
Oh. It was from Dr. Mack.
Yeah, yeah.
Good. Corey, do you have our Tuesday evening planned in Istanbul yet?
Okay, I just sent the link to Deborah.
Yes, I've got my cousins working on it. I just need to know who's going to be there on the Tuesday and how many people are flying from London with us. But we have got, I think, at least 2 nights organized in addition to the Congress.
Well, I think Robert have you gotten Salim to set Wednesday evening up now, or what?
I just got from Vince the last message, so we are now, let me check how many people, and I will send it tomorrow to Selim.
Oh, so you want Salim to organize Wednesday night then? Because
Yes.
I had asked Corey to look into it. I asked, okay, Corey, let Salim do it then on Wednesday. You're just in charge of Tuesday.
Okay.
Oh, yes, arrival list. So we are 12 people.
For Wednesday.
Yeah.
12 for Wednesday. Okay. And Selim's going to do it.
Yeah. Vince with his wife Christine, Deborah with her husband Jose, David Garber, Koray with Banu, Pablo Selim, Andrea Ricci, me and my wife Caroline, and David.
Yeah.
Jaime
Caroline's coming good.
arrives too late. Huh?
Sorry, I apologize. I arrived too late.
Yeah.
And I don't think there's any restaurant in Istanbul that Jaime likes, because all he'll eat is a well done steak and French fries.
Bullshit. Bullshit.
You know, Jaime, I love to kid you about that.
Give me some Italian pasta and you'll see how long it's in the plate.
Okay. Well, looking forward to it. Robert,
2 minutes to go, guys. 2 minutes to go.
Yes.
I mean, Robert,
1 minute.
you saw the email from Vinny about Kenny?
No.
No.
Or the WhatsApp message?
No. I was in the Expo Dental in Madrid, the industry big thing in Madrid. Very, very busy because I am doing the Spanish Society of Prosthodontics. Alfonso and I are doing that next year, and we were working for sponsors.
Okay.
Good.
Well, could Kenny,
No, but David, please stop discussions now. We are going online.
It's time to go live. Yes. Okay, Catherine, you let us know when we are live so that we can start the show.
Yes, just a minute. It is live now.
Okay, Robert.
Dear colleagues, sitting in front of the screen, I cordially want to welcome you together with Roberto Rossi and our teams here on the board for the third round of the International Challenge of the International Federation of Aesthetic Dentistry, realized together with the Italian Academy of Aesthetic Dentistry. Roberto, I want to hand over you first to say some words of greetings to our participants, and there are many dentists sitting here worldwide, from the United States to the Philippines to Japan, all over the world, looking now for this very interesting game, Germany against Japan.
Well, first of all, thank you everybody for supporting this event. It's a pleasure to be here in the semifinal. And today we will decide who will be the finalist and we'll challenge Italy in the World Congress in Istanbul on the 26th of April. So congratulations to our participants today. The semifinal will be between Japan and Germany, and we have Paul Shu, Christian Leonard, Takuya Minamino, and Takashi Atayama that will present their cases to try to win the right to challenge in the final. I just want to remind the participant, we have many people attending for the first time from all over the world. And we have to thank our 3 judges today that are David Winkler, Jaime Gil, and Koray Ferran. 2 of them are past president of the European Academy of Aesthetic Dentistry, and Koray is an active member. So they're all very prepared judges that will try to decide who is the best team that will go to the final. Just to briefly remind the rules of the game, the 4 participants will have each one 15 minutes to give the presentation. The presentation is a free presentation on a topic that is concerning aesthetic dentistry. And if they will fit within the 15 minutes time frame, they will get a bonus of 10 points. And then the judges will vote according to 4 different categories: the complexity of the case, the quality of documentation, the rationale of treatment plan, and the style of presentation. All judges will vote each of the categories from 0, which is scarce, to 5, which is excellent. At the end of the 4 presentations, we will have 10 minutes of discussion where the judges will question the participants, and then there will be a secret voting through the chat on Zoom, and we will communicate who's the finalist and the winner going to the final for the final on the 26th of April in the IFED International Challenge and Congress in Istanbul. Robert.
Yeah, so Istanbul really will be a great event. And let me show you. Yeah, here. It's now in 6 weeks that we hopefully all meet there in this wonderful city between the continents, where we have the final, where the founding team of the Italian Academy, Italy, will play against the team winning today, Japan or Germany. We will see. Good luck for everyone. And yeah, for the winners, there will be, of course, a special prize, which is supported by Henry Schein. I want to tell you, we are just in progress to prepare everything, and you will get an email with all needed details for the final, which will take place on Friday, 26th of April in the afternoon. So please mark this event in your calendar. It will be really great. It will not be transferred via Zoom, I want to tell you, because, of course, we want to have an excellent live atmosphere that you come there, but we will record it so you can see it afterwards. But all of those of you who want to participate online in presence to see how it works and who will be the winner, you have to come to Istanbul to our very, very nice 13th World Congress.
Okay, thank you, Robert. So now it's time for the game. And who is the captain of the 2 teams? Who's the German captain today? Okay, wonderful. It's Christian. And who's the captain for Japan? Perfect. So Takuya is the captain. So now, as I said before, we have our coin with the Queen Elizabeth on one side and the flower in the other side. The Germans have the right to pick head or tail because they won the other game by a larger margin. So I will toss the coin. So it's head or tail, Paul?
Head.
Head. Head it is. So I just show you. Perfect. So you decide if you want to go first or you want to go second.
We go second.
Okay, so the captain of Japan will decide who's going to go first. Is Takuya or Takashi going first?
Yeah, I'm first.
Okay, so we will have Takuya going first, correct?
Yeah.
Okay, so and Takashi will be second, and the game who you want to play against Takashi, Christian?
I will be second for Germany. Paul starts.
Okay, so we'll have Minamino versus Shu and Leonard versus Takashi, correct? Okay.
Okay.
Okay, 2, 3, and 4. So the players will be Minamino is number 1, Shu is number 2, Leonard is number 4, and Takashi is number Takashi is number 3, and Leonard is number 4. So you can start sharing your screen.
Okay.
Yes. And good luck to all of you, of course. When you will start the first slide, I will start the timer. And I will warn you 3 minutes before the end of the 15 minutes.
Okay. Perfect. Yes. Good afternoon, Mr. Chairman and colleagues. It's great honor for me to be here to speak. My name is Takuya Minamino from Japan. Today I'm going to present to you life-changing dentistry. She had many problems, both mentally and physically. The treatment not only improved her appearance, but also changed her lifestyle. So I'd like to show you how we treat her. A 50-year-old patient presents herself to the clinic with the main complaint of severe headache and backache, and she was dissatisfied with aesthetics of her smile. As clearly seen in the pictures, the dental midline was diverted to the right. She was concerned about the shifting and inclination of her teeth, and she had a strong desire to be treated. Therefore, we examined the patient totally and made a diagnosis. The frontal view showed that the dental midline was shifted 3 millimeters and inclined to the right in relation to facial midline. The chin was shifted to the right compared to the facial midline. The lateral view showed that the profile was concave type. The upper and lower lip were almost properly positioned from the E-line, and nasolabial angle was smaller than the norm. The lateral cephalogram revealed a skeletal class 3 with finger inclination of upper anterior teeth, and PA showed a significant mandibular shift of the right side. The panoramic radiograph showed that the mandible was rotated to the right and the tooth axis was inclined overall accordingly. Periodontal examination revealed a localized 7 millimeter pocket at number 35. This was diagnosed as a vertical root fracture. From frontal and occlusal views, our problem list is FDP not in harmony with facial appearance, labial gingival recession on number 22, vertical root fracture on number 35, crowded teeth and dental arch asymmetry. She had subjective symptoms of headache and stiff shoulders. The TMG findings show that the patient has had a 42.5 millimeter opening, which was adequate. There was significant muscle pain in the masseter and temporalis muscle. From the above, various considerations exist. We decided to treat the most prominent TM disorder first. Occlusal splint was used to eliminate muscle tension and occlusal interference. As a result of this treatment, the symptoms gradually disappeared, and eventually the pain disappeared completely. Within about 6 months, the patient no longer needed to take painkillers at all, much to her delight. When the CR position was checked within the muscle relaxed, it was found to be significantly mismatched with the MIP. As the splint therapy progressed, her state of mind changed. Her pain disappeared and she became more positive about further treatment. Thus, we considered how the current state of conditions occurred. The right side deviation of the mandible increased over time. The maxillary anterior teeth were restored in this condition, and the midline was inclined to the right side. Furthermore, the difference between MIP and CR position increased, resulting in muscle pain and headache. Therefore, it was suggested that aesthetic treatment would also lead to functional improvement. First step we always have to consider is where are the teeth in the face. To determine the position of the maxillary central incisors, a first mock-up was placed with only the anterior tooth axis inclination improved. However, she was not satisfied with this. Also, past Kokic literature has shown that a midline deviation of no more than 3 mm is acceptable. She strongly desired to align the dental midline with the facial midline. So we placed a second mock-up of the dental midline aligned with the face, and when she checked it out, she was delighted and wanted that treatment to be applied. So we considered which procedure would be appropriate to accomplish this. To fulfill the patient wish to obtain optimal aesthetic outcome, preserving natural dentition and utilizing orthodontic treatments seems not to be very promising. On the other hand, there are more room for both patients and clinicians by applying implant-supported prostheses for certain conditions, such as shown in this patient. So based on these diagnoses, we decided to proceed with treatment. The treatment goal is to correspond the maxillary midline with the facial midline. The sequence of the treatment plan was step 1 through 3. Orthodontic treatment first, followed by implant treatment, and finally restorative treatment. We started orthodontic treatment by an orthodontist. First, orthodontic treatment of the mandible was performed by extracting fractured tooth number 35 to align the mandibular midline with the facial midline. The use of occlusal splint was continued during the correction of the lower jaw to prevent TM disorder. In the upper jaw, only the crowding in number 24 and number 25 were corrected using aligners in the last 3 months. After 18 months, orthodontic treatment was completed. And so this was the final result of ortho. As you can see, we have a perfectly aligned lower dentition. The lower midline was coincident with the facial midline. The next step was implant placement planning. Since the mandibular midline was aligned with the facial midline, a diagnostic workshop was set up accordingly to the lower midline in order to provide 3-dimensionally proper positioning of the implants in the maxilla. Using a surgical guide based on this, the implants number 13 and number 21 were placed in the simulated positions. Bone augmentation was performed in the number 22 area where the bone was deficient, and number 21 was treated with the socket shield technique to preserve the contour of the jaw. 6 months later, a second stage surgery and connective tissue graft for number 13 and number 21, and an implant on number 23 was placed. We again applied root submersion technique for number 11 and SST for number 23 in order to preserve the jaw contour. Then we performed a second stage surgery in the number 23 and CTZ of the entire anterior region. As you can see, after 3 surgeries, the implants were placed in ideal position, reducing tissue resorption as much as possible. Now we re-evaluated the aesthetic components after setting the implant provisionals. The macro aesthetic showed that the facial and dental midline were coincident. The central incisor exposure was ideal and in harmony with the lower lip. The patient was very satisfied with anterior prosthesis display. Microaesthetic indicated that the upper and lower midline were coincident. Afterwards, the final prosthetic design was confirmed by diagnostic wax-up on casket mounted according to CR position. The mock-up reflecting the diagnostic wax-up was placed and test-driven in that condition for about 3 months. We confirmed that DM disorder did not occur and that there were no functional problems. So we proceeded to final prosthesis fabrication. First, we placed composite resin on the incisor edge of the mandibular anterior teeth to restore its morphology. Next, we placed definitive implant-supported prostheses which were reflecting provisional morphology. The posterior teeth were restored with monolithic lithium disilicate with external staining. Lithium disilicate only were cemented under rubber dam isolation using a multi-step routing procedure with combined use a 2-step self-etch adhesive system. Here you can see the frontal view of the final result. In frontal view, aesthetically pleasing results was obtained. Anterior guidance by canine teeth was also obtained. The occlusal view revealed that the molars were restored both functionally and aesthetically. This is the final result. You can tell how happy she is from her big smile in this picture, which were rarely seen previously. We were able to fulfill her greatest wish on the appearance of her front teeth display by harmonizing dental midline and facial midline.
3 more
Here
minutes.
is initial situation on the left and the final result on the right. Asymmetrical teeth is fixed and the occlusal plane is well aligned. Functional and aesthetic improvements can evidently be seen in the final result, optimizing orthodontic and prosthodontic treatment. The shifting is an inclination of anterior teeth, which was the main issue, is gone. The dentition was in harmony with the face and she was very happy with her appearance. At first, she was taking painkiller for severe headache and backache, and it was difficult for her to deal with household chores and enjoy family life. Her facial appearance also showed stiffness due to overstrain. However, as the treatment progressed, the pain disappeared and she herself became softer and more relaxed. She could now smile with her teeth showing. More than anything, her husband was pleased that they could enjoy family time together again. I believe we aesthetic dentists have great knowledge and skills that can create beautiful smiles for our patients. This is a life-changing dentistry, and this is the power of aesthetic dentistry. That's all I have to say. Thank you for your attention.
Thank you very much. That was a beautiful case, and also I think was a beautiful message. So I think the participants and people attending enjoyed very much the presentation. So Paul, is it your turn now? You have to turn on the microphone. Your microphone is off.
Okay.
Okay,
Now it should work.
perfect. So good luck, Paul, and
Thank
your
you.
screen.
Okay, I will share my screen. Okay. Can you see the curtain?
Yes.
Okay, great. Perfect. Thank you very much. I'm really, really happy and looking forward to the competition now. And I think we're learning from each other a lot. And we try to find a topic for the German team. And before we start, I want to thank our third member of the team, Clemens. He's doing an amazing job in preparing our intros very well. And I want to introduce you into our topic of both of our lectures. We made it a little bit more entertaining to bring a topic in which fits perfectly to our lectures, and the topic is older one. Maybe some of you are knowing that, and it is the topic Back to the Future. It is part 3, maybe part 4 now, I would say. We want to show the follow-up and the future. So I will do the stuff what we did in the past, and I will end with the follow-up in the future or in the present, and Christian afterwards will show what he's doing in the future with all the amazing stuff and the digital stuff we did in these times before. So the topic is rejuvenation of a smile, which is a young lady, and I want to show you this case, or I want to show you the journey of this lady and to share together what she's got. The treatment timeline is from the first contact we had in 2017. And after that, we had treatment planning and the execution and delivering 1 year later, and the follow-up or the passport control at least at right now 7 years later. So I want to start with the first contact of this young lady. She's very happy, and she has a ticket at her dentist because she's every week, or she was every week at the dentist because some of fillings is falling out or crowns, or she had some pain doing some endodontic treatment. And you can see it when I show you what is the intraoral examination. So we go first for the diagnosis, for sure. That's all the time. There has a lot changed in the last years, and you will see it afterwards. But we start with photos, and this is the first pic where we see not only the face, we have a closer look to her smile. And you can see she's a lot, there's everything into it, what you can imagine. There's grinding down some teeth, there's carriers, there are fillings, there are endodontic treatments, there are some discolored tooth, there is a smile line, which is a negative one. You can see the line of the soft tissue is not harmonized, and everything is not as nice as it could be. So in these, here you can see there's also some other problems in the backwards, but this is the first thing what we can see. Here's the occlusal view. She had some crowns, some fractures, and yeah, a lot to do to improve what we can improve in this case. The diagnostic is a little bit different, because when we start for a complex case, we need to find a starting point. Where can we start, and what is the point to begin our treatment? And here you can see we do it together with our lab technicians. In these times, we had a bigger clinic and were 26 lab technicians in there. And here you can see Bastian Wagner. He did the case together with me, and he's checking with some wax the speech and of the patient. And we taking some videos for sure. I hope you can see them, and the internet is going well to show you what's going on there, because when you're going for aesthetic solutions, you always see, okay, you make the smile of the first middle incisors as long as possible, find good proportion in something else. But I learned the most important thing is the speech and what the patient can say. Are you able to put the middle incisors as long as you want? So this is a very important thing, and we tried with a very simple thing to put something in the mouth and to talk to our patients and to see what is possible and what we can do. So afterwards, we go for functional planning, and we using the plane finder system introduced by Udo Plaster together with Circunsan. Maybe some of you are familiar with that. We're using the plane finder with a natural head position, and afterwards to find the right registration of the lower jaw, we're using equalizer for deprogramming, and put occlusal splint to check the new occlusion with our patient together. So that is before we start. And to have a better look at the X-rays, we need for sure to see what's going on there, and we need to see what is underneath the crowns and something else. So here you can see the anterior looks quite nice, but in the molar region, you can see a lot of endodontic treatment and a lot of endodontic failures. And if you have a look closer at it, you can see everything what an endodontic heart wouldn't love to see. So I sent the patient to an endodontic specialist, like always, and said, what can you do for the patient? And he's trying to make his best, but he can save the teeth 2627, 1617, and the lower also 4, 6, and 7 not. So in case of this, we have to go for an implant planning, and in these days we are not fully digital. We were not fully digital, so we plan our cases for sure with the CBCT and planning for immediate solution. We planned for extraction the upper 6 and 1/6 and 2/6 with an immediate implant placement and internal sinus lifting in there. And you can see we have a septum which is between the roots, which is quite good. It's around 5 to 6 millimeters, which we can use for our primal stability to bring the implants in. And then the lower, it looks a little bit better. You see the region of the 3-4, because this region we have no buccal plate. So we went for immediate implant placement and put in I can explain these in the details, but we go for a multi-layer technique to rebuild the buccal plate with a bone lamina from Technos to can also provide immediate implant placement and the solution for her. And in the back region, you can see it's a little bit better. And the other side on the 4-4 and the 4-6, we had a buccal bone in the better situation for going for immediate implant placement. So after that, we made our planning, and I want to be very honest with you, because the German insurance systems took sometimes very long to bring a step forward, and we had 1.5 years to get the right go for the insurance to treat her. And when we get the go, our dental technicians, we had 26, had no time. So we had to think about what can we do in there. And in these times, we decided to do this case together with a team of Christian and Francis Coachman, and to do it with the digital smile design. So it was one of our first cases we did together. You can see the treatment. This is where to start. We defined our length, what we did before. Like you can see it, you can do it very easy by yourself to check where is the stomium point, to find the starting point for your planning. And we get a really, really nice plan. First of all, this was the first smile design like they did in 2018. We matched model with the face, you all know that. And after that, we're going forward to see what is the pre-functional or the functional pre-treatment or the motivational design. And after that, we had to go for a functional design. We're using the library from F01 from Haito, maybe you know that. And this was the planning. You can see in the picture to make it to the 3D. And we planned crown lengthening in the anterior, and for sure to replace the tooth structure which was missing all there. The proportion was 81%, what we decided to have. And after that, we're going for the functional situation to get a proper planning there and to prepare everything before, because we want to go for a one-shot solution. So you can see the lower pre-treatment and the upper pre-treatment. This was not very nice to see or to show the patient, because you can see when the patient sees herself with this smile, she won't say, oh, wow, this is very beautiful, I want to have this. But that was at that time the thing we did. We had no 3D printer, but we had a lab. We worked together. They printed the models for us to go for the first provisionals and to go for a guide, which is the crown lengthening guide. Now very common, you see 2 things on there. Now it's time for the execution, and we went in for a crown lengthening. You can see what's very important to plan that. You can plan where is the bone. Is it a high crest, low crest, mid crest? You don't have to probe it. You can see everything before when you have a CBCT. So this is very amazing because your treatment is very precise, planned before you start. And this is what we did. We did it, you can see step by step, this treatment. We started with a fully anesthesia to do everything together in a one-step treatment. We reduced it with the electrotom, and you can see to measure it, to make sure where is the bone, just to check and reduce the gingiva in this. After that, we make the preps and go for the surgical intervention.
3 more minutes, Paul.
Okay, perfect. Thank you. We reduce the bone, and I love to reduce the bone with hand instruments to make it very, very clear where's the end. And if you have this guide, you can always check where it is and go for a microsurgical suturing to bring that in. And this was when we go for suture removal. She's also a smoker. You can see it in the sides where we have an open healing phase on the side. In this stage,
Paul, we don't see your screen. We don't see your screen. You press something, we don't see your screen anymore.
oh, sorry.
Presentation is off. So we stop the time.
Okay.
Go back on the screen sharing. Okay, now you're back. Okay, I start the time. You have still 2 minutes.
Perfect. This is right after surgery. Now you can see there is where the open healing on the side. You can see the typical side of smoker. And in this phase, we had the chance to get the first rehabilitation with the provisionals, to have the first test drive to see what's gonna happen and how she's reacting to the new occlusion. And here you can see that the provisional on the upper and immediate or 2 weeks later on the side. And after testing that for 6 months, we go for the delivering. And these were the final crowns from Bastian. He did in the conventional workflow, the ceramics, screw retained for the implant sides, veneering for the middle incisors in the upper jaw, and the lower from 3 to 3. You can see that ceramics, and this is the lap inside, and you can see it here after inserting them from the anterior. This is the X-ray, where you can see it fixed quite good. So this is in function 1 year later. And this is the evolution of the side of the left and of the right. You can see that. And like you saw it before, it's always nice to have these outcome for our patients because it is life-changing. I can totally agree, and aesthetic dentistry does so much more than we think. And for her, she's smiling here. Our lab technicians did that pic in his lab. I don't know what he did together with the patient, but let's see it for the last check 7 years later. We can see that here she's also smiling. It's quite stable. We are all very happy with that. You can see the X-ray timeline, and this is Back to the Future now in 2024, 7 years later. It's quite stable, and I want to say thank you for listening to me, and I'm really looking forward for the next steps. So thank you for your kind attention.
Very nice presentation, Paul. It's the game is getting better and better, and I'm very happy that the people attending are enjoying your cases. So we are off to the second game, and this time will be Christian to start his presentation. Christian, come up on the screen, please. And share your screen. And open your microphone, please, also.
You can see my screen?
Perfect. So good luck, and you can start your presentation.
So, hello everyone. Thank you for the time and thank you for everything what we have already since this semifinal. I want to start with the question, what does it mean to produce captivating smiles in our patients? And for the answer of this, we need the DNA and the parameters of the aesthetic dentistry. And for this, it's not only looking at teeth, it's more than this. It's looking at the face, it's looking at the whole procedure of our planning situation. So when we want to start with the case, we see this young lady and with different problems. We have here a problem list and where we can see that she has some intraoral and extraoral problems. We have an incisal wear, we have loss of anterior tooth length, we have crowded teeth, we have a negative crown talk on the posteriors, we have even the beginning of black triangles, even having posterior corridors. We have some recessions. From extraoral, we have a negative smile curve, short and thin teeth, and even what the patient wants to have, that she wants to brighten her teeth, and so a little bit of dark teeth. So when we go into that case, we have even different problems than we go into the X-ray of the panel, because we see that the patient already lost the first molars in the first quadrant, third and fourth quadrant, and she even lost her second molar in the second quadrant. So when we go into treatment planning, it's a huge thing to go into that, because we cannot start by selecting one problem. We have to start from the multi-perspective way of treatment. And so everything is about having a lower risk in the end for our patient and having a better prognosis for our patients. So going into such a case, it's the patient comes to us and say, okay, I have an aesthetic problem, which is dentofacial. So we had to think about what's going on with the occlusion. What should we use? Should we use a deprogrammer or a splint? Should we go forward with the MIP bite in CO or CR? What about the airway in this patient? What about using of ortho? What about the biomechanics, how to use which procedure with the technician? And what I said, it's about risk management and having a better prognosis. So we come from a facial generated treatment planning, which means that we start from the face, not from the teeth. Then we go into the function, looking forward, what is the biomechanics, where the tooth structure, which is the restoration, and then finally go into the perio, where we want to have a better prognosis for that situation. So additionally, we have now the airway perspective. So this is the way we start first in this way. And now we talk about the airway and facially generated treatment planning. So this is a new protocol. And going into that case is starting with the airway. We look at the patient and we see the smile curve and we see the facial profile, but we want to go into that patient and we want to see the structure of the teeth, the structure of the airway. And we see that there is a small compromise in the hypopharynx in that patient, but it's not too much. But we can divide it. And what is important for us as a dentist is that we have the best structure for our patients, and we want to achieve 38 millimeters of transversal volume for the intermolar width. So the structure in this patient is a flat palate, which is okay for airway. We have a PVA line with 96 millimeters, which is even nearly okay, and the SNA is okay. So we go into the function. We have a small anterior tongue tie. There's a small, no mid-tongue restriction, and a good tongue positioning. And the patient knows that she was at the speech therapist, and the speech therapist referred the patient to us. And we saw that it was a nice nasal breathing. So we go into dentofacial. So we have to know where to place the teeth in the mouth. So we have a high amount of picture what we take, but we have to know which pictures are the most important one. So we take it from the front, from 45 degree, and from the lateral. And the most important picture to exactly know where to place the teeth is the lip in repose, that's the EMMA. So we have a dentofacial risk assessment, and we see that the patient in this situation has a moderate to high risk because we see the display for his lips, and we have a high lip movement in that movement. So we measure that, and we want to know exactly where have to be the incisal edges, and the patient even wants to have more display of her teeth. So we go in, say, okay, to the patient, we plan with the smile design from the Smile Cloud. And that's exactly how to plan the case. So we start from the face and we go into the teeth. So we want to know where the proportions are. We want to know exactly where to place the incisal edges, where's the gingival architecture, and then we go into the planning with our technicians. So we have an outline like a digital smile mockup, and we see what's going on. Then we go into occlusion with this patient, and we see, okay, we have a posterior crossbite, but we have already a good transversal width of the upper arch. So that means that only the lower is on posterior on a crossbite, which does not mean that we have a functional problem after that. So we start with a COIS deprogrammer from the digital wax up. So the vertical oral dimension is based on that aesthetic wax up. And we go in, remount that bite, and we saw that the patient has a posterior open bite in that situation. And so we have to go on because the reason for the anterior tooth wear was not that the patient is grinding or bruxing, is that the way the patient is chewing, swallowing, and speaking. And so we start from the static to dynamic, and then we go into directly the Moja movement, which is a 4-dimensional movement analysis, a movement tracking system. And we exactly know how much space the patient needs. And so we can exactly plan the chewing pattern. And we saw that the patient is in a constricted chewing pattern where the lower arch has to be in the posterior way in MIP, but she wants to be a little bit more forward. And so this is the way we plan in that situation. And here you can see what's going on in this constricted chewing pattern. The patient is closing and is touching the anterior teeth first and has to constrict the whole mandible to the back to bring teeth into position. Even in the initial situation, we have to think of the biomechanics and the perio. So we saw that the patient's teeth have been tilted to the lingual. So all the negative torque makes a ground tipping, so which comes from the airway and the myofunction. We have some effraction, which causes the recessions. We have some attrition, which is coming from the chewing pattern, and we have the alveolar bone and the teeth, which are not only in the envelope of the bone, so we have a higher risk for recession in the future. So about our execution. So we go into the case, we have a planning phase, we have a wax up, ortho, and aligner, a functional reevaluation, restoration, and retention phase. So we started already with the 2-dimensional design in the DSD. So then we go into our software, it's the Exocad software, and we remount it in the face. So we go in, have a better tooth length, we can plane the posteriors in the upper, in the second step, then the lower front teeth in the third step, and the lower posteriors in the fourth step. So this is the way we do. Then we create a model from that, and then we can do a mock-up from that situation. So in this situation, we have 2 ways, and we did both for the patient to find the best way to do a direct or indirect with a milled provisional or with an injection molding provisional. And then we can leave the patient with that and say, okay, how we adjust it to a characterization. And then we know exactly where to place our teeth. And in this situation, we want to be as less invasive than we can be. And so we bring the teeth in the right position, but we do it with ortho. And so we have the initial planning phase, and we exactly can bring the teeth in the best position for the future restorative outcome. So it's dentofacial and functional guided ortho. And then we have all the planning phases. We can go into that. And after 7 months, we have the teeth in the best position. Then we do even a re-evaluation with the modular 4-dimensional tracking in that patient. And we go into that because we have done a posterior open bite into provisional tabletops. And we design those tabletops directly, not with milling or printing. We not with drilling, only with printed tabletops. And then we bond them directly to the teeth. And now we have a better function, we have a better overjet in the front, and we have more space for the movements. So we have a better clearance in that situation. And so we even do that to the front with some provisionals by adding some composite in the front. And we have now a stable MIP, and we can go directly into the restorative phase. So we go into that preparation. We use some guides even for drilling the teeth. And then we have the jigs to transfer it to the lab. We do it on both ways because the teeth are too narrow of a situation for the contact points. And then we have this backward planning from initial to the wax up to the prep and the final situation. And then we can overlay that. So we go into the initial, having the wax up, going into the prep, have the lab work, and then having the final restoration in that situation. So we need space for prosto, and we get it. So the dentist, the lab could start directly by using individual dentin shades. We use lithium disilicate for that. And we go into the bonding phase. So we bonded all the teeth, even with the bridges and the posterior.
3 more minutes, Christian.
Thank you. So this is now the final result in that situation. Patient is able to do everything. We check it. And from intraoral perspective, we have a better vertical oral dimension. We have a better aesthetic outcome. We reduced all the risk for the future phases of dentofacial, of airway, of function, of the biomechanics and perio. And we see all this picture in the mouth, a stable function. We did not place implants. We worked with bridges. We did some pontic site development with connective tissue graft in the posterior with that. So before better cleaning situation. And this is the upper, this is the lower. And this is the final result after our whole treatment. And for me, as a statement for all of you, is that treatment planning was and is the future in aesthetic dentistry. We now have more possibilities, as you can see, with the digital way, because we can improve a lot way for more predictability, to be more or less invasive, and to exactly know what we do. So I want to say thank you to all of you. And yeah, it's a pleasure for me and my whole team with Paul and Clemens for being here. And we hope to see you in Istanbul soon. Thank you.
Well, great job. You finished ahead of time, so everything is perfect. So we now pass the screen to Takashi Atayama so that we can conclude the semifinal, and then we will start the discussion with the judges. Atayama, are you online?
Okay.
Perfect. Can you please share your screen?
Can you see my slides? Can you hear me?
Perfect. Yes. We can hear you and we can see you.
Okay, thank you. Thank you for this great opportunity today. Tokyo Tower is especially beautiful at night, so please be sure to visit when you come to Japan. Let's begin the presentation right away. The title is Monoblock Direct Composite Crown for Saving the Pulp and the Root. Monoblock restoration refers to the method where whole crown is restored using only direct composite. This restoration has been performed in our department for some time now, and I will also introduce the prognostic data that has been collected. So let's start. First, let me introduce myself briefly again. Now, I am an assistant professor in cardiology and operative dentistry at Tokyo Medical and Dental University. And I strongly think in all moments that direct composite restoration is the quickest and the most gentle treatment for patients regarding minimal invasive concept. Today, I'd like to share a story of a young man who couldn't smile. This patient was a case that my prosthodontist friend and I worked on together, consulting a treatment plan. He was 34 years old, office worker. His chief complaints included difficulty eating and hypersensitivity. This is the first photo. He had a severe tooth wear. It was clear at first glance that vertical dimension increase was necessary for him. I interviewed him to understand why he ended up in this condition. Unfortunately, he belonged to a toxic company, experiencing too many stress without getting enough sleep, leading to repeated vomiting. As a result, his teeth gradually eroded and he completely lost his smile. His treatment wishes were able to smile again, preferably with minimal invasiveness. Additionally, since he didn't have much money, he also hoped to keep the costs down. Orthopontomography is showing the slide. There is no periodontal problems. However, left central incisor has apical periodontitis. It was necessary to test the pulp vitality of all teeth. Two upper central incisors were non-vital. However, vital responses were observed in other teeth. All of lower teeth were vital. All molars also showed vital responses. What are the problems? Severe tooth wear can lead to various issues, no failure effect for anterior and so on. However, as a positive aspect, at the initial visit to our university, he had already changed his workplace, relieving him of stress, and vomiting had completely stopped. Taking everything into consideration, we propose a treatment plan. First, we will use provisional overlays based on the diagnostic workup. After root canal treatment and resin core buildups, temporary metal onlays will be placed on the molars to maintain the occlusal plane. Then, monoblock direct composite crown will be performed to the anterior teeth, followed by ceramic restorations for the upper central incisors and the molars. He agreed to this plan and was relieved by the non-extraction plan because he had initially thought that many teeth would need to be extracted. Why did we decide to select monoblock direct composite crown, MDCC? Here, I will introduce the concept of MDCC based on my data. These all models has no failure. In the MDCC model, low shear stress on the root surface occurs. However, in zirconia crown model, high shear stress occurs at the root surface edge. Moreover, choosing MDCC fully utilizes direct bonding ability across the entire surface. However, when choosing the zirconia, the highest stress area at the edge relies on indirect one. It is widely known that the bonding strength of indirect one is significantly lower compared to direct one. We need to predict how restoration will fracture. With MDCC, less stress on the root surface means inside the composite fracture is expected. With zirconia model, strong stress occurs, leading to complete detachment with the core, like this. Another important thing, it often happens that crown fracture with the root structure itself. This type of failure is the most challenging, you know. It may require extraction or some surgical procedures. This underscores the importance of achieving a Ferrou effect in crown restorations. Furthermore, if indirect restoration is chosen, it would result in losing sound enamel, remaining slightly mesodistally, which is advantageous for bonding. This slide presents the clinical performance of single MDCC. Dr. Tashiro reported the success and the survival rate of single MDCC over 40 months. Overall, the results are promising. The second set of clinical data was reported by Dr. Miki. He investigated the odds ratios of prognostic factors for MDCC. In his findings, the Ferrou effect did not affect the survival rate. On the other hand, the bonding procedure with SLDP reduced the risk of failure by 1/20th. What is SLDP? SLDP means smear layer deproteinization pretreatment. After preparation, the dendrin surface is covered by smear layer like powder snow. The self-etching primer cannot dissolve all of the layer, and the organic phase inhibits the penetration of the resin monomers. Therefore, 6% sodium hypochlorite can dissolve the organic phase, making it easier for resin monomers to penetrate the dentine. Then the surface is washed for 30 seconds. However, the oxidizing effect of sodium hypochlorite can negatively affect the polymerization of the bonding. To counteract this, a reducing agent such as a sodium sulfonic acid is applied for 10 seconds to neutralize the negative effect. Then air dry. Following the SLDP procedure, the adhesive system of your choice should be applied. Our department reported that SLDP allows for long-term durability to be achieved. However, the original two-step system works very well for many cases. It is recommended to use it aggressively for cases that rely on adhesion only to dentine, such as MDCC. SLDP has also a good effect on eroded dentine. The surface of eroded dentine is disadvantageous for bonding because the inorganic component is dissolved by strong acid, leaving behind a thick organic phase. So bonding strength decreases like this. Cutting with burr is one method. Chemically approach SLDP dissolves the organic layer, leading to improved bonding durability. This is why we choose MDCC with SLDP for him. Sorry for long explanation, but I wanted to make sure everything understands that MDCC is possible. Let's go back to case presentation. We conducted a diagnostic wax-up and fabricated the first provisional restoration. We had discussions with the patient and made a detailed adjustment. After ensuring no issues with vertical dimension over 6 months with temporary metal onlays, at this stage, we replaced the second provisional restorations. In the first provisional restoration, there was an over contour here. So in the second provisional restorations, we adjusted the ringer margin. The smooth transition of the margin here is the most crucial point when making a silicon guide. Since a monolayered index would result in poor adaptation in the margin, so we prepared a bi-layered index this time to accurately replicate the margin. By extending the guide overlapped the incisor edge, we were able to accurately transfer the anterior guidance. I performed MDCC from the lower incisors using the guide. In cases like this, there is a risk of trapping air bubbles during multi-layering. So I opted for a monolayer technique to maintain uniform mechanical properties. For these restorations, I only used Majesty ES Flow universal shade. During the second visit, I made a new guide and performed MDCC on the lower canines. I focused on polishing without paying attention to fine details at this stage. During the third visit, I performed MDCC on the upper lateral incisors and canines. This is a final view after finishing the MDCCs and completing ceramic restorations by the prosthodontist. Each time he received our treatment, he was surprised and delighted. As a result, his smile gradually improved. This is a lateral view. Functionally appropriate cuspid protected occlusion has been achieved, leading to proper disclusion of the molars. The opposite side as well.
3 more minutes.
Thank you. 2 years prognosis. The anterior guidance we provided has been maintained. The patient is also using a sprint against bruxism. This is the area I restored. Composite is often criticized for its wear issues, but so far there hasn't been significant wear. Of course, I believe it's important to carefully observe any changes in occlusion and tooth movement regularly in the future. Before the treatment, he couldn't smile at all and felt hopeless in his life. Above all, he didn't want to worry his family, so he avoided seeing them. However, he is now able to smile again, laugh with family, and can eat anything. I haven't imposed any specific dietary restrictions because I believe that having restrictions would take away from the enjoyment of eating. If MDCC were to break, it would likely fracture inside the composite, making it repairable immediately. So I told the patient to rest assured, and he was really grateful, feeling like he is being given a second chance. So in my conclusions, monoblock diet composite crown is the last resort to save the pulp and root. Second, SLDP helps improve bonding durability and reduce the risk of failure for MDCC. Finally, please respect the patient's mind, what they're thinking and feeling against our proposal. Some dentists say that composite is temporary. However, my mentor, former Professor Tagami, once said, life is also temporary. That's true. So I believe that in order for individuals to use their own teeth permanently in their temporary lives, it can contribute to the patient's happiness in life. Therefore, what is important is not just the external appearance, but the invisible internal integrity as a bonding surface. References from our department. Thank you so much for your kind attention. Dankeschön.
Well, guys, I can just say that I'm very happy and proud of all of you because you did a wonderful show. And I would not invite the judges that now have to judge your work because it was really outstanding. And you would all deserve to go to the final, but unfortunately, only one team will move forward. So now I would like to invite our judges to interview you. And we have our most fun judge to start. Dave, please go ahead with your questioning to the participants.
Thank you, Roberto. All four of you, congratulations. Amazing work. I'll try to keep this short with just one question per each of you, and I'll do it in the order that you did the presentations. So Takoya, again, amazing work. I will leave the occlusal discussions and the discussions about the TMD diagnosis to Corey. He's much better at that than I am. My simple question will be, you did it over a 6-year period. Was there any relapse in any of your initial diagnoses?
Thank you for your question. Yeah, relapse or she used the occlusal splint now and as a retainer, and she has no PM disorders. She came my clinic every 3 months. So so stable. It's good.
Excellent. So she is content with the result of the outcome of the treatment.
Yeah.
Yes.
I hope.
Good. Thank you. Paul, you mentioned that the anterior teeth were in pretty good condition on your patient. You decided to only go to the first molars rather than including the second molars. Was the patient given the option of the second molars? And what was the rationale of only including first molars?
The patient was not wanting the second one, and the prices for the second one also increases. So that was a main reason to decide to go just for the first molar. And we are checking to get a proper occlusion with the first molar, and that was the case here. And so that was the main reason to decide to go just with the first molar. Yeah.
Excellent. I agree. Corey might not agree with you. He wants to put 28 or 32 teeth in a mouth. I believe in this shortened dental arch concept, which is very Scandinavian. So that's fine. Thank you, Paul. Christian, objective versus subjective findings. Were there clinical medical diagnoses about the compromised airways and function, or was that just something that you discovered objectively?
I always do an analysis of the airway in every patient when we come to a treatment. So in this situation, we have a mild narrow arch. We have a flat palate. So we know that we are from the literature with aligners. We have a good tongue positioning, and so the risk for relapse is not too high. So it's so important to go on all of our cases into the thoughts of airway, not only for having space, even for sleeping, for breathing, for swallowing, and all those other dimensions which is opening in airway.
Excellent. Thank you very much. Last but not least, Takashi, based on your title, I was thinking, how can you compete with the first 3 cases? And then when you showed the initial situation of this young patient, it was obvious that was as comprehensive a treatment as the first 3. I am a composite person myself, again, compared to Corey. You had a 2-year review of that. On other patients, Do you have longer reviews of complicated cases with composite, and do they hold up over a 5-year period?
Thank you for your question, your comment. So I don't have long-term patients, so it is the first time to restore the monoblock restoration to many range. So I don't have a clinical data about long-term durability, but I think rare resistance is of composite is one issue, but composite is repairable. So I carefully observe the occlusion, and if the composite is rare, additive approach is acceptable, I think.
Excellent. Thank you very much for that, gentlemen. I just hope my team, Manchester United, today does as well as the 4 of you did today. Very, very impressive. Thank you. Roberto?
Okay, now we give the microphone to our new judge and guest, Koray. So it is your turn.
Thank you, everybody, for
And Dave, you can already send me your votes through the chat as I ask you to vote for each individual participant so that I can start recording the votes.
So thank you very much for putting together these wonderful presentations. I know how much time these take and how much effort goes into them. So wonderful. Again, I will go in order if I may. So Takuya, you mentioned the fact that the patient had quite a mandibular asymmetry, but no temporomandibular joint dysfunction. So is there any way that you in the absence of any clinical symptoms, what do you feel was the reason for her asymmetry? Was it something she was just born with, or was it a functional problem?
Okay. Yeah, thank you for your question. Yeah, I totally yeah. Maybe I think it's a functional problem. Most of function problem, but yeah, the CR position is still deviated, was deviated to the right. So a little bit, yeah, just bone situation.
But you were happy the condyles were seating and the discs were in place, and the asymmetry you just have to accept.
Okay. So only stable occlusal and use occlusal splint protect the mandible.
Thank you. Thank you.
Thank you.
Paul, that was a fantastic recovery. And I love the laboratory photo at the end. She looked very happy. It must have taken her a long time to get into that state. What are the processes that you and maybe your hygiene team go through to prevent that sort of thing happening again? Because it's obviously an extensive reconstruction. How do you, see, this is someone who's neglected their teeth. How do you prevent them from neglecting their teeth again?
That's a very, very good question, because we always in front of these patients, but he was very, very motivated, and he got really, how should I say, not the best dentistry before. So she was not the best cleaner and everything else. That's true, but she got so many bad fillings and so on. So she had no chance to clean that. So we brought or we took she in 3 times per year, and she's coming and did her best. And that we check in the phase of the occlusion splints and of everything, preparing and planning. So I think for her it was quite easy, but we have also many patients where it's a problem and where we have to discuss when we took a treatment like this, can we start it after 2 or 3 years from the beginning, because there is going down the hill there. For us, it's the most important thing, the maintenance, and we take them 3 times a year to check that and to make it proper that she's able to clean the best at home. So that was for her the main reason to get in this situation, I think. Yeah.
Thank you. Thank you. Christian, I was blown away. I think that was a masterclass in how to have of applied technology and documentation. I really have very little to say. I'm just very jealous I can't do what you do. It was a beautiful case, and I really like the way that you incorporated airway when when we're using deprogrammers and directive splints now. Airway has become a big issue, and it seems to be getting more and more well diagnosed in sleep studies and everything. So it was really nice to see that included. I can only commend you. I really have no questions. I thought it was just beautifully done, and I wanted to say thank you for sharing it.
Thank you, Corey.
Takashi, thank you. That was a very brave case on somebody who obviously needed a lot of care and attention, not just for dentally, but also emotionally. And you have obviously changed that young man's life. So congratulations on that. Thank you also for going through your bonding protocol. What I would have loved to have seen is the clinical steps. Whether you isolated the teeth, you didn't say whether the teeth were isolated when bonding is such a critical part of the process. Were you using rubber dam, and how were you isolating the teeth, which is something I would have liked to have seen. And I would also just want to say that in the event that one of these does fail, how do you do the same thing again, or would you have a backup plan with an alternative technique?
Okay. Thank you for your question. First, your question is rubber dam isolation. Since perfect rubber dam isolation is difficult in this case, so I use the split dam technique. And second, your question, alternative plan. If the composite is completely break, I can use a surface is clean up and indirect resin cement, the re-adhesive. Yeah, rebond. Yeah. Or create a new guide and re-entry. Yeah.
All right. Thanks. So you would use the same technique again?
Yes, if possible.
All right. Thank you. Thank you very much. That's me done.
Okay, so now we leave the word to our last judge. I invite you, Jaime, to make your questions, but in the meantime, to send me your votes through the chat so that I can put the numbers together and pass it on to Robert. Jaime, your time.
Thank you, Roberto. First of all, congratulations to the 4 lecturers. Their presentations were excellent, and we are most proud of you. As member of the jury, I have the duty to make a comment and a question. Addressing Takuya, my question is, you placed 3 implants in this patient, correct?
Yes. Yes.
Would it have helped for the prognosis if you would have placed a 4th implant in place 11? Or why did you not do it? What is the reasoning?
Yeah, thank you for your question. Yeah, number 11 position is I don't use replace the number 11 implant because of the exists of incisor foramen because of the her facial midline is left compared to the dental maxillary suture. So I don't I cannot place the implant on number 11 because no bone.
Okay, thank you, Takuya. Thank you.
Thank you.
Going on to Paul. Paul, your clinical case was certainly very interesting. The way you treatment planned and executed was excellent. The only comment I would like to make in this patient is how much time did you wait since you finalized your crown lessening procedure to then continue and take impressions to finalize the case?
6 months. We wait half a year. Yeah.
Thank you. That is what we teach in my university. Thank you. Going on to Christian. Christian, I agreed to the previous comment. Your case was impeccable. So I have to think in what can I ask you for such an impeccable resolution. I love the airway concept. I think everything was very well explained. I only have to congratulate you for it. I don't have any questions to you, Christian.
Thank you.
And to Takashi, my comment to Takashi is, it is a brave treatment planning, and I certainly wish you from the bottom of my heart the best of luck for the prognosis of the treatment. But one thing we especially teach our students in my university, is you have to base every treatment on scientific evidence. You did mention 2 papers, and one, the study was done on 71 cases. The second one, it was done on 94 cases. Are there any more references that you could quote, or are these the only 2 references we have on the monoblock composite restorations?
Yeah, thank you for your comment. It is true that there is not enough evidence. The data on single MDCC cases have been reported, but the number of cases is still limited. So I also offer MDCC to a patient who have consented, but further analysis is needed in the future, I think.
Well, thank you very much for your answer. Most proud of you. Congratulations to you and to the other 3 lecturers. Thank you. Thank you, Robert.
Okay.
Thank you, Roberto.
I have to say that never like this time, your vote will be important because we have a very close game. So I'm looking forward to seeing your votes because we are in a very tight contest, and I hope you will make it more interesting. Robert, you can make your comments, turn on the microphone while Jaime is sending me his votes, and I will endorse you the scores so that we can close this semifinal and nominate the finalist.
Yeah. Again, congratulations also from my side. The first 2 rounds have been incredible. The 3rd round now was as incredible like the others, maybe again a little bit more. So I'm very much looking forward to the final in Istanbul, what we will see then there. Yeah, but first we have to know, yeah, who will be the finalist, and it's always a really very hard decision, yeah, between such excellent teams, dentists, and yeah. Let's see who has the luck of the game today. Roberto, you've got the final votes?
Oh, I'm still waiting for the votes of Jaime. I have
Okay.
all the other votes, but
So
I'm still
Jaime
waiting.
still is
in
working.
the chat, please, Jaime.
Yeah.
I've sent them through the chat, but maybe I did not
No,
do
you
it.
have to address it to me.
No, WhatsApp to Roberto.
Address
Okay.
it to me. Send it to me.
Yeah, and then you will see.
Well,
Yeah,
all
but
I
I
want
hope.
to say is that was a wonderful journey, and not only this for semi-finalists, but even those that were eliminated in the first round were excellent. So the purpose will be in the future to have more games, because many of the people that were eliminated surely deserved to be participating more. So we will find a new formula for the future where there will be more games, maybe with just one single case, not with two cases, and maybe with a single tooth treatment, or with things that can make more people participating and making more games, so that we can have more fun and we can find more talents, because actually this was a talent show and we really found a lot of young talents through these games.
Yeah,
And
yeah.
I am sure
If you
that
have
there
in
will
mind
be-
that all in all, at the end we will have seen 56
Being in
cases.
charge of the new internet.
Which is really,
Yeah.
Jaime, I'm still waiting for your scores.
I'm working at it.
Robert has asked
Hey,
me. to
you
be in
want to
charge.
send it to me via WhatsApp? Maybe it's faster.
I'm doing it. That's what I'm doing.
Okay, perfect.
May I say
Okay.
something while we're waiting? Jaime, your comment about things having to be based on scientific evidence, and Takashi having done this based on a couple of papers. If we don't do it, there will be no evidence. So he has to do it to have the evidence. And he has lost absolutely nothing. If one of these
Exactly.
fails, you're back to square one. You haven't done any crown lengthening, you haven't done any endodontics, you haven't done any tooth cutting. It is purely a conservative approach. And I think that this actually should maybe be the third, at least a case study as a paper, and follow it up. But I think it's the most conservative way of treating that patient, and I would like to commend you on it.
Yes, Corey, I definitely agree with that. If you don't experiment, there is no advance. The only thing is when teaching students, like I teach, it is very important to teach them that scientific background is essential, because if not, we will convert our treatments on patients in human experimentation, which would not be accepted.
No, I agree.
But as Corey also mentioned, though, you're back just to square one, as you haven't touched the tooth. There's been no biological compromises to that tooth, which there would have been with an old-fashioned prosthodontic crown and bridge work. But again, I'd like to just say, Robert, you have asked me to be in charge of the International College of Speakers for IFED. I mentioned it last time. Again, all four of you should be part of that, and I will contact you through Robert to discuss joining the new International College of Speakers. Guys, phenomenal work. Thank you very much.
yes. I will send during the next 2 weeks an informational email to all players, what our intention is, what we expect, what we want to do, and hopefully most of the players, and I'm sure that from the older teams, they also are online and looking now for the next levels. They will hopefully come to Istanbul, and maybe we can make there a short personal meeting with everything. And yeah, let's see.
Well, Patrick, have Jaime's scores.
Yeah. I have everything. Let me just double check one last time because I want to make sure that everything is fair.
Yeah.
So I will send the final scores to Robert. So game one was between Paul and Takuya. So and the second game is Christian. Okay. Okay. Let me just compute the total.
We should have the Champions League theme playing in the background. Have a little music while we're waiting for Roberto to add this up. Robert, can you deal with that, please?
Okay, that's it. I'm sending you the scores and then Robert can.
Yeah, but Roberto, you can. Of course, you did it the last time, so do it again.
Can't hear you. Roberto, can't hear
You're
you.
muted.
I am pleased to say that the winner is, but the loser is not. But I mean, there is only one winner. The winner is Germany. So we will have a football match like we had many times in history, Germany versus Italy in the final, by the score of 134 to 120. The first game went to Germany, 64 to 60, and the second one to Germany, again, 70 to 60. And I have to congratulate Christian because for the first time, a participant who got a full score. So he got 60 points from the judges. So congratulations. That's a remarkable score. And I'm very happy that all of you did a fantastic work. And I'm looking forward to meeting you in Istanbul and have a great time all together. Robert, you can
Everybody,
close.
have a great Sunday, everybody.
Yes.
Have a great Sunday.
And,
Thank you, everyone. Thank you for inviting me.
and see you in Istanbul.
Good luck to all of
Definitely.
you guys.
Definitely.
Good luck.
Congratulations
Good
to all.
luck. Ciao.
Bye-bye.
Thank you all.
Bye.
Thank you. Ciao.
Bye.
Bye.